So, good morning, friends. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic, not much talked about in scientific fora, and that is past, present, and future of fetal medicine. And to deliver the talk, we have very young fetal medicine expert, Dr. Haley Shah. She did her MBBS and MS in Surat from Government Medical College. And she did her fellowship in basic fetal medicine from VNSGU. To her credit, she has a publication in the Journal of Fetal Medicine on Serenomelia case series. She has several paper presentations at various conferences, and presently she is working as consultant at Sagar Hospital. So welcome, Dr. Haley. Nice to see you back in academic circles in Baroda. So please go ahead with your talk. And you have about 40 minutes to talk, and we'll have some 10-15 minutes for discussion. So over to you.
Yes, sir. Thank you. Okay. Thank you for the introduction, sir. I would like to, the topic for today is the past, present, and future of fetal medicine. So I would just like to take you through the journey of fetal medicine, how it started and what happened when. So just let us start. So this is a very famous ad in our fetal medicine. It was featured in the Super Bowl ad. It is actually an ad of chips Doritos in which this husband of this female is eating Dorito chips during the ultrasound scan. And as you can see, the fetus is asking for the chips. And then bam, she delivers. So that is how important fetuses have become today, that they are featured in Super Bowl ads. So fetal medicine actually is a subspecialty or a super specialty of obstetrics. And now fetus is not just only an entity or just a living thing inside the womb, but it is treated as a separate patient itself. So this branch of fetal medicine is dedicated to the care of the unborn. And fetal medicine is not just only for the abnormal babies or high-risk pregnancy. It is for everybody. It is for the masses. So 90% of our job is declaring that the fetus is normal. So now we are in an era where the fetus and the mother are both treated as different patients. So we have the obstetrician whose patient is the mother, and then we have this fetus who is the fetal medicine consultant's patient. So this is a very newly developed branch, just 40, 50 years down the line, and it is specifically dedicated for the unborn. So the aim of fetal medicine is to give society only all happy babies. So what happens is the work does not end when we deliver a baby and give it to the couple. It ends when 5 to 10 years down the line, the baby is neurologically intact and doing well in life, and is not suffering from any problem that could have been picked up in utero. So delivering a neurologically intact baby who is doing all good is specifically the aim of fetal medicine. So when we hand the baby over to the pediatrician or the neonatologist, we wish that the baby is in the best of the health to be taken care of. Okay, so I just like to go in history. Let us start with the 1860s. In 1860s, Robert Langdon Down first described what was Down syndrome in an observation which he called ethnic classification of idiots. He said that the skin is too large for the body, the nose is small, and the face is flat. Then it took us 100 more years to know that Down syndrome had a scientific basis, and it was Jerome Lejeune who came up with the concept of trisomy 21 for the Down syndrome. He was very fond of children with Downs. And then it took only 10 more years for a means to get this diagnosis by the means of prenatal diagnosis of amniocentesis. And there was this journal published in the Lancet journal on how to do amniocentesis and for the diagnosis of Downs. So with amniocentesis, they put a needle into the abdomen of the woman through the uterus skin, and they take out amniotic fluid, culture the amniotic fluid for the fetal cells, and do karyotype. So then in 1960s, we knew that we had a problem, which was the Down syndrome. We had a scientific basis for the problem, which was the trisomy 21. And we already had a method to diagnose the problem, which was amniocentesis. But still we were delivering babies with Down syndrome because abortion was not legalized. So in 1966, abortion was legalized in England. And only 5 to 6 years down the line, abortion was legalized in India. But mind you, this abortion legalization in India was only till 20 weeks of gestation. Recently, it has been increased to 24 weeks of gestation, which is a milestone achievement for fetal medicine in this year, 2022. So in 1970, when we came to know about the Downs and the method of diagnosis, a lot of people came up with statistics, and then we came to know that Down syndrome was associated with maternal age. 30% of fetuses with trisomy 21 were born in women more than 35 years of age. But then there was a glitch that the vast majority of the women delivering were less than 35 years of age, and this accounted for 70% of the women with Down syndrome. So screening only women above 35 years of age with amniocentesis did not help us, because we could pick up only the 30% of cases of Downs. The 70% cases of Downs were missed. So universal screening of Down syndrome is important. Offering a screening for Down syndrome in today's time, irrespective of the age of the mother, is the new protocol for screening. Then we had people measuring all different kind of hormones in the maternal blood. So initially we had only maternal age for screening. The detection rate with maternal age was only 33%. Then they took into account alpha fetoprotein. With alpha fetoprotein and maternal age, the detection rate increased up to 44%. Then we had a triple test. This was a landmark achievement. They took into consideration maternal age, alpha fetoprotein, unconjugated estradiol, and HCG, human chorionic gonadotropin. All these hormones were measured from the maternal blood approximately between 12 weeks of gestation to 18 to 20 weeks of gestation. Now, triple marker test is obsolete. Nobody does a triple marker test in fetal medicine. If the baby has missed the screening in first trimester for Downs, a triple marker test is not advised. We advise the patient to wait till the patient reaches 14 to 15 weeks, and then we advise a quadruple marker test, because as you can see, the detection rate of a triple marker test is 78%, while that of a quadruple marker is 86%. But the standard of care today in fetal medicine for screening of Down syndrome is a combined test. A combined test meaning that it includes an ultrasonography at 12 weeks of gestation, which is basically known as an NT scan, and it includes some hormonal levels like pre-beta HCG and PAPA. PAPA is pregnancy-associated plasma protein A. It is associated with angiogenic factors of the placenta. So in 1990s, when we were doing the first trimester scan, this is the fetus. Fetus in first trimester at 12 weeks is approximately 6 centimeters in length. And at 6 centimeters, we can see a whole variety of things in the fetus. We can see the brain, the hands, the nasal bone, the palate. We can see the heart, the cytus of the baby, the stomach, the liver, the kidneys, the bladder, and a lot more. So they came up with concept of the black space behind the neck, which specifically is known as nuchal translucency. This nuchal translucency they found was increased in fetuses with Down syndrome. So if you combine this scan with some soft markers in sonography, like the presence or the absence of nasal bone, the flow across the ductus, that is the junction between the umbilical cord and the fetal heart, and a tricuspid regurgitation in the fetus's heart. Combining all these soft markers plus the hormonal levels of PAPA, beta HCG, and PLGF, we could identify 97% of fetuses with Down syndrome with a false positive rate of 3%. So this took place in 2000 and 2010. So presently, we are following this protocol of combined first trimester screening for the fetuses, in which there is a sonography, which is known as the NT scan. But believe me, at 12-week scan, we do a lot more than just NT. It is basically, we can pick up almost 30 to 40% of anomalies at the 12-week scan. And majority of the aneuploidies meaning trisomy 21 or trisomy 18 or 13. So we had an evolution over a period of 40 years from the description of the problem, the scientific basis of the condition, to a means of prenatal diagnosis drastically improving every 10 years. This is how a branch emerged, dedicated itself to the care of the unborn. So now, while this was emerging and everybody was seeing with the hormonal levels and everything, we also realized that not only the fluid behind the head was associated with Down syndrome, it was also associated with various other problems. If the fetus at 12 weeks had increased fluid behind the neck, it later on could also have some cardiac defects, lethal skeletal dysplasia, a long list of syndromes. It could also lead to some infections like parvovirus B19. And so the early diagnosis, the thing shifted from the late diagnosis of fetal anomalies, say at 28, 30 weeks, to early diagnosis of fetal defects. So if we do a 12-week scan for a pregnant lady, we can diagnose anomalies of the CNS like holoprosencephaly. Easily we can diagnose spina bifida or open neural tube defects, anencephaly, or defects of the anterior abdominal wall like defects of omphalocele or gastroschisis. Basic defects of the heart which are actually not compatible with life, like hypoplastic left heart syndrome or Epstein's anomaly, megacystitis. All this can be diagnosed very easily in the first trimester scan. We also realized simultaneously that if we were screening patients in the first trimester, and if we took into account some other parameters like the history, the uterine artery PI, which is uterine artery PI is actually we measure the Doppler of the uterine artery at 12 weeks, and the pulsatility index of the uterine artery is taken into consideration. Then mean arterial pressure and PAPA. This can predict 80% of pregnancies with preeclampsia. So preeclampsia, with increasing gestational age in pregnancy, with increasing obesity in today's world, with increasing ART, artificial reproduction with IVF, with many women getting pregnant with chronic conditions like hypertension or diabetes or SLE, all these ladies tend to develop preeclampsia in later life. And preeclampsia leads to preterm birth, and many a times we lose the baby. So detecting preeclampsia at 12 weeks itself, so that we can prevent it to an extent or decrease the severity of it by giving a simple aspirin tablet of 150 milligram. But this has to be done before 16 weeks, while placentation is complete. Before placentation is complete. So detecting it before 16 weeks was a milestone achievement, and we can now do it with very easy prediction, very easy predictor markers. Similarly, we can detect small for gestational age baby with the same criteria, because preeclampsia is going to have a small for age gestational baby. Early prediction of preterm birth with history, cervical length, and serum AFP. A simple transvaginal ultrasonography at 12 weeks will give you the cervical length. If the cervical length is less than 2.5 centimeters, and if the patient has a history of previous preterm birth, simple we offer cervical encirculation to the patient, and the preterm birth in 70% of the patient will be safe. If the cervical length is only less than 2.5 centimeters, if the patient does not have a previous history of preterm birth, Giving simple vaginal progesterone tablet till 28-32 weeks of gestation is going to save the baby. A simple measure, the tablet not even costing more than 10 to 15 rupees, is going to save a life. But detecting this at 12 weeks is important. So basically, the pyramid of prenatal care, initially, what we still do, what the obstetrician visits are still like is every week, every month you come till 28 weeks. So till 7 months, we call the patient every month. Then the visit starts every 15 days from 30 week onwards till 36 weeks. And then it is every week till 41 weeks. So this pyramid actually says that majority of the problems in pregnancy were detected in later gestation. When the problem was already there and we could not do anything, we could just detect it. But there's no point in detecting a problem when we cannot help the woman. So this inversion of the pyramid, detecting anomalies, detecting problems at 12 weeks, then offering some type of solution is the inversion of the prenatal care pyramid. So at 12 weeks, we can detect preeclampsia, preterm delivery, gestational diabetes, major aneuploidies, and we can stratify the patient, whether the patient is a normal patient or the patient is a high-risk patient. If the patient falls into the high-risk category, then we offer a specialist care from 12 week onwards. 12 week onwards, we do an early anomaly scan. At 22 weeks, we do multiple growth scan. And so, since we already know that the patient is high risk, the antenatal care of the patient is going to improve. So, if I put down the history and come back to the practical aspects of fetal medicine, the basic thing is that we rule out mental handicap and associated abnormalities and syndrome so that we can prepare the couple that, okay, your baby is normal. When you deliver, you can go home happy, no problem. But if there's a small problem, we can potentially tell the couple whether it is correctable or it is not correctable. If it is correctable, okay, say for example, if the baby has a small VSD, we all know that a small VSD is going to close postnatally. We can tell the patient, okay, you can deliver in a setup where you can deliver in a private nursing home or wherever you want to deliver, and the baby is not going to require any further care. But if we know that the VSD is large and the baby is going to require a surgery, it is my job to inform the obstetrician and involve a pediatric cardiologist so that the pediatric cardiologist can prepare the couple. Kitna kharcha hoga, where the surgery is to take place, when the surgery is to take place, how much it is going to cost, and what all they have to do. So this involvement of different experts for the management, for the optimum outcome of the baby is very important. Our job is to provide the information. We have to tell the patient the baby has this anomaly. These anomalies are compatible with life. These anomalies are not compatible with life. Majority of the couples understand incompatible anomalies need to be terminated. But if we are terminating an anomaly, please refer the patient to a fetal medicine expert before termination of an anomaly because of the risk of recurrence. If, say, for example, if you have a baby with anencephaly, one hand absent, there's spina bifida, or there is cleft lip, cleft palate, and we don't know what is the syndrome or what is the risk of recurrence, a simple DNA extraction and storage. Simple DNA extraction from the thigh of the baby, from the umbilical cord, from the placental tissue, anything that you can find post-delivery, you can just store it for simple 2,500 rupees. This myth that majority of the fetal medicine tests are very costly and majority of the patients cannot afford it is just a myth. If you just store the DNA at say 12, whenever we terminated the pregnancy, next time the couple gets pregnant, at a 12-week scan, we just screen the baby. If the baby is all good, I just take a placental biopsy. Placental biopsy means a simple chorionic villus sample. Sorry. And we match this sample of placental biopsy with the previous stored sample. If both the samples match, it means that since they are sharing that kind of DNA, the baby is going to develop some kind of anomaly and I can easily terminate the pregnancy at 12 weeks. So a reference before termination to know the chances of recurrence is very important because nowadays we also have options of doing in vitro fertilization with PGI, which is pre-genetic implantation. So before implanting the embryo in the mother, I'm going to check the embryo, whether it has any anomalies or not. Okay, so that was the basic counseling part of fetal medicine. And I will just brief you on the basic ultrasounds. If we were to follow a standard of care in pregnancy, how many ultrasounds ideally the lady should have? The first is an early pregnancy or the validity scan. This is very commonly known as the dating scan. This is done as soon as one comes to know about the pregnancy. Usually, a transvaginal scan can be a transabdominal scan. It is done to confirm the gestational age of the fetus. Not only the gestational age, we need to see a lot more things, whether it is an ectopic pregnancy or not, whether there's multiple gestation, whether there's subchorionic hematoma or not. Everything you come to know in this dating scan. Okay, so this I've already talked about the 12-week scan. If the dating scan is all normal, we give the date for the 12-week, which is essentially the 3-month scan, popularly known as the NT scan. But we all know it is a lot more than NT. We can detect approximately 50% of anomalies at 12 weeks. So why is this important? Why this NT scan is so important is because in India, the upper limit for termination has been increased to 24 weeks. But it is very easy to terminate a pregnancy at 12 weeks by simple suction evacuation rather than carrying on the pregnancy till 20 weeks, the patient being attached emotionally and mentally to the baby and then doing a preterm delivery. So it is very easy legally, it is very easy medically for the patient as well if we diagnose an anomaly at 12 weeks. And then we have this anomaly scan. If the patient is poor, not able to afford this kind of antenatal care, then if she has to undergo only one scan in pregnancy, it has to be the anomaly scan at 18 to 22 weeks, because in this time, approximately 90% of the organs of the baby are weak. So if I do an anomaly scan, fetal abnormalities will be identified in 2 to 5% of pregnancies. And why this is important? Because fetal anomalies are responsible for 21% of perinatal death. This anomaly scan is known by different names like TIFA, which is targeted imaging for fetal anomalies. It is also known popularly as a 3D or 4D scan. Many people call it 5D also, but there's nothing like a 5D to fetal medicine till now. These all are still images in 3D, which we can see. So this also helps patient to bond with the baby. Okay, so I was bragging how important is the 12-week scan, and now I am telling you all of a sudden that no, the 20-week scan is more important. But why is that? So I found this paper in which they had compared all trained sonographers screening women at 12 weeks and then again at 18 to 20 weeks. They found that abdominal wall defects, majority of the abdominal wall defects were diagnosed in the first trimester. In CNS, all abnormal like acrania, encephalocele, and encephaly were diagnosed in first trimester, while other anomalies like spina bifida was overlooked. So they could only diagnose 6 out of 14 anomalies in CNS, but other after these 6 other anomalies were diagnosed in the anomaly scan. If we look into the heart, the CVS system, the detection rate in first trimester was only 19%. All the remaining cardiac defects were diagnosed in the 20-week scan. If we take into consideration the skeletal anomalies, only 17% were diagnosed in the first trimester, which are essentially the limb reduction. But minor skeletal anomalies like the fingers, polydactylity, syndactylity are all better seen at 20 weeks. If you take into consideration the kidneys and the bladder, 5 out of 33 were diagnosed, so 15%. So anomalies like hydronephrosis, uretrocele, double collecting system are all diagnosed at 20 weeks. So overall, no cases of GIT, respiratory or facial anomalies are diagnosed in the first trimester. And so it is very important, if we are missing these anomalies in the first trimester, it is very important to do a consecutive scan when we can see these anomalies. So the 20-week scan is important. But also, you have to keep in mind that successful detection of an anomaly depends on the gestational age of the fetus. If you are doing a 12-week scan at 11 weeks, then the rate of detection is going to decrease as compared to doing a scan at 13 weeks. It also depends on the time that you allocate to a single patient. Ideally, our protocol says that spending approximately 30 minutes for the first trimester screening, and 45 to 50 minutes on the anomaly scan is the standard of care protocol. Obviously, the person has to be trained. It also depends on the maternal body habitus. So if the patient is obese, the probe penetration is going to be poor. And it also depends on systemic examination of fetal anatomy. So if I'm going to randomly see the fetus, obviously I'm going to miss something. But if I have a protocol that I have to see the brain, the spine, the legs, the hands, the kidneys, and the organs. So this is just a table which is important because you can be legally in trouble if we miss an anomaly, which is always detectable. You cannot be held responsible for missing an anomaly which is occasionally or never detected. But missing an anomaly which is always or mostly detected, it has to be detected. Okay, so now we've declared the patient is all, the baby is doing all good, the baby is all okay, and the baby goes ahead 20 weeks, 22 weeks. Then we have to see the growth of the baby, whether the baby is gaining adequate weight or not. For that, we have the growth and the Doppler scan is the last part. So the sonography was essentially in 4 parts: the viability scan, the 12-week scan, the anomaly scan, and the growth and the Dopplers. Why these growth and Dopplers are important? We know that the baby is all normal, but we also need to know the weight of the baby, whether the gain in weight is adequate or not. Because with increasing incidence of gestational hypertension, diabetes, maternal obesity, we are very often there is a growth restricted fetus or macrosomia because of diabetes. So the mode of delivery, when to deliver, that answer, when to deliver the baby, is given by doctor. So it is very essential to time the delivery in case of FGR fetus, otherwise we are going to lose the fetus. FGR fetal growth restriction. Okay, so if I put all of you to sleep, my fetus is requesting rub your eyes and wake up, because I'm going on now to some very practical aspects of fetal medicine with a bit of theory, of course. So, okay, so these are new advances in fetal medicine. I am going to explain this concept of cell-free fetal DNA for NIPT, that is non-invasive prenatal testing. Very commonly talked about tests in OBGY. So this concept of cell-free fetal DNA, how it comes. So when the cells die, the DNA from the nucleus is broken down into fragments and released into the blood for all the cells. So when the lady is pregnant, there is a lot of activity in the placenta and the baby, and a lot of DNA is broken down and released into the maternal blood. So in the maternal blood, there is going to be DNA from the mother, from the placenta, and from the baby. Okay, so there are going to be 3 types of DNA in the maternal blood. So now, if you imagine a very tall building, okay, imagine that every floor of the building is built with different colored bricks. Now, if the building falls, there's an earthquake and the building falls, and if we have to collect the bricks from the rumble, and if we stack the bricks, we will then come to know the number of bricks which were used to build each floor. Similarly, if I take a sample from the maternal blood and I separate all the DNA and then weigh the DNA, I will have a baseline that chromosome number 1 should weigh this much, chromosome number 2 should weigh this much, chromosome number 3 should weigh this much. So this forms the basis of cell-free fetal DNA. If the fetus is going to have some anomaly, take for example trisomy 21, there are going to be more chromosomes because there is trisomy. The 21 chromosome pairs are going to be more because it is trisomy. So in maternal blood, I will find more of fetal DNA, fetal 21 chromosome. So this is the concept behind NIPT. So NIPT stands for non-invasive prenatal testing, but it is not actually a non-invasive test. We actually do take a sample of maternal blood. Not non-invasive, but an expensive but extremely good screening test. and it is basically used for trisomy 21. The detection rate for trisomy 21 is 99%. So almost as good as invasive screening tests like amniocentesis. Detection rate for trisomy 13 is 96%, and with trisomy 13 is 91%. The interpretation of the tests in twins is a bit dicey because what DNA comes from which twin depends on whether they are sharing a placenta or not. And it also depends on the baseline risk of the background risk of the woman, that is the a priori risk, and the fetal fraction. As the pregnancy advances, the fetal fraction, the fetal activity is going to increase. So the fetal fraction in the maternal blood is going to increase. So my test sensitivity is going to improve. So non-invasive prenatal testing, NIPT test, can be offered to all pregnant ladies from 9 weeks onwards till 20 weeks of gestation. But it will be better offered when the fetus is big. So it is better offered when the fetus is 11 to 12 weeks till 20 weeks. Okay, so this is the basic protocol that we follow for screening of aneuploidies. So we do a combined screening, which we already know is a combination of age, USG, in which we do fetal entry, serum beta HCG, and PAPA. If this combined screening comes normal, and that is low risk, nothing else needs to be done. We can reassure the patient that everything is okay, you can go home happy. If the patient falls in the intermediate risk, we offer this non-invasive prenatal testing, NIPT. If it comes positive, you have to offer a confirmatory invasive test, which is amniocentesis or a chorionic villus sampling, in which we actually take the DNA out from the baby or the placenta, culture it in a lab, and see it. And if the patient is high risk, more than 1 in 10, then obviously we need to confirm this risk with an invasive test. Okay, so this is all about the diagnosis in fetal medicine. I would like to give some very minor information on fetal interventions. Okay, so this forms a very happy topic for us fetal medicine consultants, and fetal therapy is a very soothing topic, as in the results for best interventions are in fetal therapy. So fetal interventions, I can basically classify it into 3. Blood transfusion for anemia. So this is intrauterine transfusion to the fetus for anemia. Endoscopic laser for twin-twin transfusion syndrome and selective fetal reduction. And fetoscopic endotracheal balloon for CDH. So I will explain this intervention on basis of case study. And I will go through them quickly because I don't have much time. Okay, so case 1 is multigravida Rh negative, 28 weeks of gestation with a very typical obstetric history of first normal delivery. The baby was Rh positive, followed by 2 neonatal deaths, query cause of IVF, we don't know. So this is a very typical history of Rh hyperimmunization. Now, if we do an USG, we find that there is fetal ascites. You can see a lot of fluid in the abdomen, then you can see pleural effusion near the lungs. And you can see some pericardial effusion as well. So this is a hypertrophic fetus. Essentially, there is fluid everywhere. So a very simple Doppler of MCA, middle cerebral artery, can detect an anemic fetus. Why? Because if there is anemia, there is going to be, the baby is going to shunt the blood to important organs, brain being one of most important organs. So if the PSV, that is the peak systolic velocity, in the middle cerebral artery is increased beyond 1.5 deviation, the standard deviation, it means that the fetus is anemic and we can do something about it. So this is a slide showing intrauterine transfusion. You can see the needle going through the umbilical cord and transfusing blood into the fetus. So this is, we require O negative leuko-reduced, irradiated, fresh blood for the fetus. And once I diagnose that the fetus is anemic and it has a lot of fluid everywhere, we simply transfuse blood. Like if there is anemia in adults, we would like to transfuse blood. So we paralyze the baby by giving it an intramuscular shot of paralytic agent. And then we simply transfuse blood through the umbilical cord. and the amount of blood to be transfused depends upon the hemoglobin of the baby. So initially, when we put the needle through the umbilical cord, we take out blood from the baby, quickly run through the HB, and then we know how much amount of blood has to be transfused. Okay, so most rewarding form of fetal therapy is intrauterine transfusion, because we can deliver healthy babies which will only require exchange transfusion at 34 weeks of gestation, and we can save those babies if the lady has been isoimmunized. Okay, case 2. This is a simple case. Elderly primigravida conceived with help of artificial reproduction, very common nowadays, and she has triplets. She cannot financially support the triplets. She is not emotionally prepared for triplets. What to do? This fetal reduction comes to use. What is fetal reduction? Okay, so fetal reduction has increased. Why? Because we have been increasing use of ART. We know IVF has become very common. We do ovarian hyperstimulation for the same. If there are twins, one twin is anomalous, say it has NNKFERI, the other twin is normal. To save the normal twin, we have to reduce the abnormal twin. It is sometimes the patient decision, like patient is thought gravid, already having 2 live babies, and the patient has conceived twins naturally. The patient might want only one baby. So there are ethical concerns over fetal reduction, as in why are you killing a fetus when it is doing all okay? But if you look at the bigger picture, see if you have triplets, the possibility of all the 3 babies surviving at 34 weeks of gestation is almost 40 to 50%. 50% there's a chance that we are going to lose all 3 babies. If we reduce triplet pregnancy to a twin pregnancy, then there is almost 70 to 80% of chance that the twin pregnancy is going to survive. So if you think ethically on these grounds, that if the baby is going, okay, we are not letting one baby grow, but the remainder of the babies might have a good chance of survival, I think we are okay ethically, and this has been approved by all ethical committees all over the world. So, okay, a quick go into the type of twinning, which will better help you understand how we do reduction. If the twins are dichorionic, diamniotic, means they have conceived from 2 different sperms and 2 different ova, they are going to have different placentas, they can be of different genders, they do not share anything. They are as good as 2 siblings conceived over a period of time, but together. In twins, they are together. Then you have monochorionic diamniotic twins, in which they share a placenta, but the amniotic membranes are different. And then you have monochorionic, monoamniotic twin, in which there is nothing different. There is no amniotic separation, anything. So for monochorionic, monoamniotic twins, you cannot do anything. You cannot reduce one, because if you try to do anything to one baby, since they share a placenta, whatever you inject in this baby is going to go to the other baby, and the other baby is going to die as well. So a fetal reduction cannot be done for monochorionic, monoamniotic twins. Okay, so this is a video of fetal reduction. You can see this needle. This needle will come here, and simple, we inject KCl into the baby's heart, and we wait for it to stop. The needle is going inside. Okay, intracardiac injection of KCl for the fetus. Okay. Okay, so this intracardiac injection of KCl we can only do if they are not sharing a placenta. This is dichorionic, diamniotic twins. They are not sharing. There is a thick membrane between. They are different twins. So if I inject any toxic product into this baby, it is not going to go into the other baby because the placenta is not the same. But if they are sharing a placenta, what we do is fetoscopic laser reduction. So this is basically the amniotic umbilical cord insertion at the placenta. Then we trace these veins. Okay, we are tracing this is the umbilical cord of the placental end, and then we are tracing these arteries and veins to where the anastomose to the other baby. So there is essentially a recipient and donor in twin. And then with laser energy, these anastomoses are coagulated. Very recent technology, only available at some centers in India, specifically Chennai and Bombay. Okay. Used when there is one anomalous baby sharing placenta, or used when there is twin transfusion syndrome. So, okay, this is a very common case scenario in which there's a primary Sindhi caste or say Punjabi caste, and hemoglobin is 8, low hemoglobin despite giving oral iron, the 12-week scan is normal. Then the hemoglobin is 8, the obstetrician does HPLC, and we come to know that, okay, the patient has thalassemia. The patient has thalassemia, very common in India, because if the woman has thalassemia, the high possibility of arranged marriages. So the other person, other partner might also be belonging to the same caste and might also have thalassemia. A thal minor and a thal minor, or a sickle minor and a sickle minor, 25% chance that the fetus can be a major. So, very easy to diagnose. A simple chorionic villus sampling or simple amniocentesis can tell you whether the fetus is major or not. We are preventing neonatal mortality, perinatal mortality, simply with diagnosing antenatal. So, very easy to diagnose this thalassemia major, but we need thalassemia and sickle major if we have a history. Okay, the latest advance is for diaphragmatic hernia. So what was the problem with diaphragmatic hernia? That we could easily diagnose it antenatally, but we never knew the exact defect. So in 1990s, what they did was they did open surgery and repaired the diaphragm. They removed the herniated viscera, pushed it down to the abdomen, and so there was adequate space for the lung to expand. And this was the first surgery done in 1990s. But then they came to know that if you simply occlude the trachea, and not push the viscera out of the thorax, then occluding the trachea is going to lead to fluid accumulation in the lungs. So lungs are going to expand and push the viscera out. So this is a very recent development, which is fetoscopic tracheal occlusion, FETO, which is done for congenital severe diaphragmatic hernia and gives very good results. The baby is actually saved. Okay, so my fetus is saying bye, but I am all open to questions. And this is the end of my presentation. Okay.
Yeah, thank you, Ali. That was very interesting. The last one,
Thank you, sir.
the closing slide was very meaningful, I would say. Yeah, you can stop sharing so can have some
Yes,
questions.
sir. Yes. Yes, sir.
So as far as interventional fetal medicine is concerned, have we progressed much? I mean, in India, or there is a lot of things yet to be done?
Yes, a lot of things have to be done, sir. That is true. But we do offer, some centers in Chennai do offer fetoscopic laser for TTTS, selective fetal reduction. There is feto technology available in India for diaphragmatic hernia, but the cost is still a major factor in India. So if the patient is affording, say, conceived with IVF and affording, we have patients who are willing to go to Chennai and, do reductions and everything.
So any other questions from the audience? They are welcome. I think Sabnam is asking, let me look at the chat. Dr. Sabnam has asked, can VP shunt done in which week?
Yes, for ventriculomegaly or obstruction, VP shunt can be done, but the results have not been promising. So any fetal intervention is usually done around, say, 27 to 29 plus 6, around 30 weeks, because that time we get optimum space inside. For this, essentially, the VP shunt, there's no laparoscopic VP shunting technology at present. So we do open VP shunting. So for open VP shunt, the fetus has to be small. So ideally, the best time to do it will be at 26 to 29 plus 6, but not promising results. Patients usually prefer to terminate the pregnancy because since there is already ventriculomegaly, the normal cerebral tissue has already been damaged by that 26, 27. But it can be done, yes.
Another area of work in fetal intervention is renal anomalies.
Yes, sir. Renal anomalies, we do shunting. Very commonly done, sir, shunting in Chennai. But then it all depends on whether majority of the fetal medical anomalies are evolving. So initially at 20-week scan, when we see only say bilateral pilectosis, which is borderline, and if it progresses, now there is such good neonatal ICU care that the patient prefers to deliver the baby a bit early than to undergo these interventions. So if I have a good neonatologist or an ICU center, my pediatrician is going to say, okay, I can handle a baby of 1.2 kg, take it out. So the patient will be all okay, delivering preterm, then undergoing fetal intervention. Because still the risk of fetal intervention, losing the baby completely, is still there.
Dr. Hemant Sant has asked a question about legal ethical issues, path for fetal reduction or abortion based on fetal medicine diagnosis.
Okay, so if we have a discordancy for anomaly, so if we have twins or triplets in which one baby is anomalous or say two babies are anomalous or anything, so what was initially done, this whole concept of fetal medicine came into being after we started doing a lot of ART or IVF. So what is seen normally is that when we do IVF, the IVF people are very expert in taking out ova vaginally and doing everything. So it is very simple for them to go transvaginally and reduce the sac at say 6 to 7 weeks. So if we have done ART and if we have say triplet or quadruplet pregnancy, it is very easy for me to do sac reduction at 7 to 8 weeks of time. But at 7 to 8 weeks of time, I don't know whether the fetus is normal or not. So what essentially happens at 7 to 8 weeks of time is that without it is a blind thing. The most approachable fetus is reduced. I don't know whether it is normal or not. So this, if the patient consents for a reduction, it is legal. If the patient does not consent for reduction, it is illegal. Other ethical issues, fetal reduction is ideally done at 12 weeks. So we do not allow the fetus to grow beyond 12 or 13 weeks. Otherwise, the dead fetal mass is going to be so much that aborting the dead fetal mass is going to lead to abortion of the live one. So the legally everything is correct. The only thing is that the patient does not like it ethically killing a baby, but then we have to explain the risk that the survival of the triplets is going to be lesser than the survival of the twin. So legally, fetal reduction has been given a green sign all over the world. All the associations, even FOGSI and the SFM, that is the Society of Fetal Medicine, has approved of fetal reduction everywhere. So that is not a problem. Okay, cost of combined screening. So that is I take it that is basically the first trimester screen. So the NT scan depends on the NT scan is somewhere between 1,500 to 2,000 rupees, and a simple double marker is going to cost you 1,000 rupees, or say maximum that a good lab is going to take is 1,000 or 1,200. So that I don't think in today's day is that much amount to give if you are ruling out employees and saving a life. And the cost of NIPT is somewhere around 8 to 10,000. That is still an expensive test, and we have a long way to go. Okay, thank you, ma'am.
So I got disconnected.
Okay. Ellie, diaphragmatic hernia can be managed after fetus is born. Why
Yes,
we
sir.
need to do?
Yes, sir. Diaphragmatic hernia can be managed, but what happens that the lung is not enough developed. Because of the vista being pushed into the thorax, the antenatal development of the lung does not expand only. Usually the left lung. So we have these whole studies in which we usually do a liver to heart ratio, lung to heart ratio, and this ratio usually gives us prediction for the post delivery survival, post surgical survival. So if this ratio is less than 1.5, then we need to do feto, that is fetoscopic tracheal occlusion. Then only it is done. If the ratio is in good terms, less than 1.5, then the baby does not need feto. The baby is going to survive postnatally with a simple surgery. But only thing that their lungs do not expand even after surgery. For that, we do feto.
Any other questions? I think there are not many questions now. Sorry, in between I lost my connectivity, so I missed some part of your answers. So thank you, Ellie, for being with us. It was wonderful, a brilliant presentation, I would say, and a new insight into a topic which is not much talked about. So thank you very much for being with us. We expect you
sir.
to
My
deliver
pleasure.
some more talks in future also.
My pleasure, sir.
Thank you. Thank you.
Thank you.
So we close the meeting here and we meet next Saturday again. Thank you all. Thank you.
Thank you.